you for sharing my slides with you.
Yes, sir.
So the first, this question is asked: sepsis and septic shock management, or just asked as full question. First, you have to define what is sepsis and septic shock. Sepsis is a clinical syndrome of life-threatening organ dysfunction caused by a dysregulated response to infection. So the basic thing is there is an infection in this patient. That is the basic thing which causes a sepsis. The word sepsis itself is meaning infection or entry of a microbe into your body. So that is those days we used to say wound has become septic. Septic means there is a infection which has entered your body, which is causing a life-threatening organ dysfunction because your host defenses are not properly taking place. Whenever you develop an infection, immediately you develop leukocytosis, white cells. All of you would have studied in your basic classes that white cells are the soldiers to come and protect your body, fight the entry of the extraneous organisms and try to help you. At the time, because of the fight, there is a rise in body temperature, increase in metabolic rate, and all those things happening. So that is a normal response. But when this defense mechanism becomes dysregulated, then that is condition is called the sepsis. And in septic shock, there is a critical reduction in tissue perfusion and acute failure of perfusion to organs including lungs, kidney, and liver. So these are the two definitions that you have to know about. The causes of sepsis, that is a very important component that you have to know. Causes are immunocompetent patients or many different species can be affected by gram-positive and gram-negative bacteria in the and in immunocompromised, incompetent patients, these are the organisms which cause the sepsis. And immunocompromised patients, the uncommon bacteria along with gram-positive and negative, you may have also have uncommon bacterial and fungal sepsis. So these two category of patients you have to know who can be affected by sepsis. One is immunocompetent patients. That is a normal patient developing, say, first pneumonic in consolidation because of gram-positive or gram-negative bacteria. They can also go into sepsis. And immunocompromised patients who are on immunocompromised agents like post-transplant patients who are on suppressions, or cancer patients. These are all patients who are immunocompromised. They can develop not only the common infections like gram-positive and gram-negative, but also bacterial and fungal infections. And the clinical signs will be tachycardia, fever, hypotension, oliguria, and confusion in severe states. And diagnosis is done by primary clinical with the culture results to show that you have to prove that there is an infection. So there should be a culture response to the particular organism which has to be grown in culture to know that it is a sepsis condition. And the features of septic shock are it involves persistent hypotension and which may not respond even after a heavy dose of fluids. That is a characteristic of the septic shock. We may be giving 30 ml per kg per day or hour, and then even that time it is not going to respond. That may require the support of a vasopressor to maintain a mean arterial pressure of more than 65, and the serum lactate level goes on increasing, and it may be more than 2 millimoles per liter despite adequate fluid resuscitation. And the category of people who are affected are is often neonates, older adults, or pregnant people. These three categories are more prone for contracting this among the immunocompetent patients. Of course, immunocompromised patients, they are potentially always under threat, so they have to be guarded more from the falling into sepsis. The predisposing factors in patients who are immunocompetent can be diabetes mellitus, cirrhosis, leukopenia, invasive lines, prior antibiotic or steroid therapy, and if they have been admitted for the hospital for some other problem, they are also more prone to develop a hospital-acquired infection and go into the state of sepsis. And which organs are the common sites of infection? Which organs are affected most commonly to produce a sepsis? Lungs is the most easily affected because the aerogenous spread is very common. Then urinary tract infection, especially in the elderly who have some retention with overflow problem. Biliary infection, GI tract. So the order of common affection, lung stands the first, then UTI, then biliary, then gastrointestinal tract. Now, the pathophysiology of this sepsis and septic shock, there is an inflammatory stimulus, either by a bacterial toxin or the proteins that are produced by that, and triggers production of pro-inflammatory and anti-inflammatory. The pro-inflammatory will be the first one. Body will try to produce anti-inflammatory cytokines also, but the pro-inflammatory, if it overruns the anti-inflammatory, then the sepsis becomes more deeper. So these cytokines cause neutrophil endothelial adhesion, activation of clotting mechanism, and generate microthrombi. And this microthrombi formation is another reason for decreased perfusion of the organs. So they also release numerous other mediators, including leukotrienes, lipoxygenase, histamine, bradykinin, etc. And they are opposed by anti-inflammatory mediators. That is why that word dysregulated hormone response is included in the definition. So it is not that body is just sitting idle and trying to allow these invaders to come in. It tries to oppose by producing anti-inflammatory mediators like interleukin 4 and 10, resulting in a negative feedback mechanism. But initially, arteries and arterioles dilate, decreasing the peripheral arterial resistance. Cardiac output comes to support by increasing it. So there's a compensatory tachycardia and increase in cardiac output to maintain this perfusion. And this stage has been referred to as warm shock. So initially, body will try to somehow adapt to that particular changes that are happening in the peripheral circulatory state. And later, after a particular time, this cardiac output maintenance cannot be continued. So what happens? It may decrease, blood pressure falls with or without increase in peripheral resistance, and this typical features of hypoperfusion occur, and that will become from warm shock, it will become a cold shock. So even in the stage of increased cardiac output, vasoactive mediators cause blood flow to bypass the capillary exchange. So the basic problem here, even with the increase in cardiac output, microcirculation is not able to take place properly. The blood gets directed before it enters the microcirculation, and that is why it is also called the distributive defect. And at a particular time, the patient will become peripherally very cold, and blanching will not happen. So poor capillary flow resulting from the shunting, along with capillary obstruction by microthrombi, decreased delivery of oxygen to major organs, and impairs the removal of carbon dioxide and waste products. So they start accumulating, resulting in acidosis at that particular level. So oxygen is not getting delivered. Whatever carbon dioxide and waste products are produced, they are not being removed because of the lack of microcirculation. So decreased perfusion causes dysfunction, sometimes failure of more than one organs, including the first one will be to get affected will be the kidneys, then the lung, liver, brain, and heart. And the coagulopathy may develop because of intravascular coagulation with consumption of major clotting factors. And excessive fibrinolysis in reaction also, and more often it will be a combination of formation of microthrombi and exhaustion of all your coagulation factors. So what are the investigations to be done? CBC will show differential with a differential count, which will usually show a increase in WBC count, white cells and total count, and the electrolyte imbalance may happen. And if the kidney is already under low perfusion, you may have a raised creatinine, urea, and all that. And invasive central pressure and partial pressure of oxygen will also be low. With the venous oxygen saturation, more extraction will happen. So you will find the venous oxygen and total venous oxygen level will be much less. And cultures of blood, urine, and other potential sites of infection will show presence of any organism which has invaded. So what is the treatment that has to be given? The pillars of treatment, first and foremost, because it's an infection, appropriate antimicrobial should be given. So culture samples are required for administration of antimicrobials, and treatment should be based on clinical, epidemiological, and criteria promptly started, and frequent reassessment of patients' response to these particular antibiotics and antimicrobials should be done. And procalcitonin levels also can be measured. The next thing, the next important treatment is fluids. So balanced crystalloids or other fluids can be given. So as much as small repeated bosons of 250 to 500 ml, depending upon the. So fluid therapy and fluid responsiveness have to be assessed repeatedly to assess the status of the hemodynamic stability. Then third step is the vasoactive drugs. Vasopressors may be needed after fluid therapy if it is not able to sustain and produce an improvement in the mean arterial pressure. Immediately, don't wait, go for supplementation. So normally we use norepinephrine in doses of 0.1 to 1.2 microgram per kg per minute. And vasopressin, if the noradrenaline is not effective, the alternate is to go for vasopressin. Then the fourth step is the oxygenation and ventilation support. So that can be done with a non-invasive initially, and then we have to go for invasive if the condition is very severe. Then the fifth step is the other treatment. So you have to sometimes use heparin, both to prevent microthrombi as well as DVT, or you have to go for low molecular weight heparin. You have to use insulin for maintaining the blood sugar levels, and you have to do proton pump inhibitor. If the kidney perfusion is affected and renal function getting deranged, you have to think of renal replacement therapy, steroids to support the vasopressors in case vasopressors alone are not effective. Then sodium bicarbonate to correct the acidosis, which may be severely happening because of the lack of tissue perfusion. In pH less than 7.1, you can think of sodium bicarbonate, and acetaminophen should be administered to keep the fever and other things under control. So that is the, and of course the resuscitation, initial sepsis bundle and that is called resuscitation and maintenance bundle. Earlier it was, the timing was different. Now they have reduced it to 1 hour and 24 hours. So all those initial bundles also can be included in your answer as a supplement, which I have not mentioned because of lack of. So that also can be added in your answer. Okay.
Yes, sir.